Today's episode is brought to you by Microsoft Dragon Copilot, your AI assistant for clinical workflow, which helps to ease administrative burdens. We don't like those.
They are the
Those are
worst.
terrible.
There are way too many in healthcare.
Automatically document care, streamline workflow, and just help you build a good patient-physician relationship. That's what it's all about. Learn about how Dragon Copilot can transform the way you work. Visit aka.ms/knock-knock-hi. Again, that's aka.ms/knock-knock-hi.
Knock, knock. Hi.
Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenfleck, and this is your one-stop shop for all things eyeball related. I've got some fun topics for us today. We're going to do toward the end, we'll do a little potpourri of different eye things. I don't have like any big topic in particular. I'll just go over like a handful of things that I think are kind of interesting, and hopefully you think they're interesting too. In my experience, if someone who knows a lot about something is just talking about something that interests them, and that is just interesting to listen to. I hope that's true. So we'll get to that here in a little bit. First, I just want to tell you about my trip recently. I went to what was it called? Old Saybrook, Connecticut. Old Saybrook. So I went with Lady Glockenflecken and a couple of our wonderful producers, Aaron and Rob, to Middlesex Health, which is in Middletown, Connecticut. And we did a show for all the staff. We did our Wife and Death show where I dress up in costumes and we have like music and there's no dancing, but it's a multimedia show. It's really fun. They rented out this theater as this Katharine Hepburn museum slash theater, about 300 seats or so. And it's a full house. It was great. It's so much fun to do that for just hospital staff in like a random place in the country. Go to them and just have a fun night where people can get together outside of work, assuming you all like each other, and just kind of let loose and just have a good time, have some drinks, have some hors d'oeuvres, and laugh at an ophthalmologist telling testicle jokes. And it's like, what more could you ask for a night out, honestly? And it just really does seem like a big morale boost. And what I learned though is that this group, Middletown Health, is an independent hospital. And so I've talked about this before. This is one of those things. I made a video about physician-owned hospitals maybe a couple years ago. A bit of a niche topic, but an important one in medicine, especially when you know the stats, the data behind physician-owned hospitals versus the other entities that can own a hospital. By the way, you know who can own a hospital in this country? Certainly corporations, private equity firms, insurance companies, churches. All these things can own hospitals, but you know who can't? Physicians. That was snuck into the Affordable Care Act. One of the bad things about the Affordable Care Act. I think the Affordable Care Act, and there's been a lot of talk about the Affordable Care Act recently, just because of the government shutdown and the fear of premiums going up. I think premiums go up every year, regardless of whether or not we have the healthcare subsidies in place. But it does seem like they will be going up even more. But so the Affordable Care Act, it did some good things, right? It got rid of pre-existing conditions, allowed people to stay on their parents' health insurance until they're 26. Some really good things. But it also gave a lot of power to the insurance companies, and I don't know if people really realize like that would be like the extent of that problem down the road. And we're seeing the repercussions of that, right? As these health insurance companies, they have so much money, they're consolidating healthcare. We don't need to go into all the details, but we know like that's a big problem. And the Affordable Care Act did enable that to happen. And the other thing that the ACA did that a lot of people don't like is a ban on physician-owned hospitals. And that was a specific thing that was lobbied for by, well, guess what? Like the American Hospital Association, like the big organization for like corporate hospitals, hospital systems, right? And so, and the data shows you guys that you get better care, cheaper care, and people enjoy working at these independent hospitals more than your HCAs of the world or your private equity owned hospitals. Like it's just a better working environment and it's just better for patients. Unfortunately, they're going away because of this ban. And so there's, all the ones in existence, including Middlesex Health, where we just were, they were grandfathered in after the ban went into place. There's a lot of active advocacy work being done to try to get rid of this ban because it doesn't make any sense. Why? I guess the concern is that it's a conflict of interest for the doctors working in the hospital to own the hospital. You want to talk about conflict of interest? Like, look at health insurance companies who are are they have obviously they provide health insurance, but they also own their own pharmacies, and so they can force patients to leave their existing pharmacies and use their own pharmacies. And by the way, also they are the largest employer of physicians, and so it's all the vertical integration. That's not a conflict of interest. Be able to direct people to your own services. Like what are we talking about? Why is that even a consideration? It's silly conflict of interest. Like just look at what the data shows. That's all we should care about. All right, is it good care? Is it, and it's not only that, but it's like cheaper care. It I so for like you can miss me with this conflict of interest crap because it's better care. It's better care. And so and you can feel it when I go and I really like doing these types of like hospital system talks. And I've done a couple, I think, for like physician owned hospital systems. And usually it's just one hospital, but a lot of times they're big hospitals. Like this one, I think they said their staff at their hospital is like 450 total. Um, you can feel that they're proud of it, right? That they're proud to work there because it's people that know what it's like to take care of patients. They know what it's like working as a healthcare professional, seeing patients in this healthcare system. And they are the ones that are making this thing run, that are making the decisions, that are in leadership positions in the hospital, that are running this hospital and making hiring decisions and quality improvements and all these things. They're making it go. Wouldn't you want someone that actually knows what it's like to take care of people in that role? Like, it makes too much sense for us to have a ban on any new people coming in running a hospital. Any new physicians coming in and running a hospital. I mean, I'm not saying every physician is going to do it ethically or well. Certainly there are physician-owned medical practices that go under because of bad decision making, but give us a chance. We're smart people. I say we as if I'm ever going to own a hospital. I am allergic to hospitals. You all know this. I'm an ophthalmologist. What do you know what? When you see, if you're in an ICU, you see someone dressed up in like kind of like nicer clothes, carrying a piece of luggage, looking scared. That's an ophthalmologist. They're lost. Help them find their way out of that place. We don't like hospital. We don't go to hospitals. We don't, I will go to a surgery center that's like as close to a hospital as I can stomach. So this would not even benefit me. But it would benefit patients. It fires me up to like even think about like this as a legitimate thing that we should be worried about. Oh, we can't let physicians own hospitals. We How could anything be worse than what we got already, you guys? Like, what, you want United Healthcare to own it? You want a private equity firm to own it? We know what happens when that occurs. So give us a chance. Nah, silly. All right. let's do a couple of questions. Anyway, I just shout out Middlesex Health. You were a great audience. It was so much fun meeting all of you. I want to try to do more of these physician-owned hospitals. Maybe do some content around it too. Like get the word out. Like these are great places to work and go seek medical care. All right. I got a couple of great questions recently. So the most recent video that was published was I talked a lot about vision therapy. I got some interesting comments. Some people that didn't quite agree with me. I was a bit critical of vision therapy. I want to clarify like what I'm referring to when I say, because I think a lot of people are thinking certain things are I would consider vision therapy, but are not actually vision therapy in the general definition of what optometrists consider vision therapy. Patching is not vision therapy. Patching is a legitimate, not to say all vision therapy is illegitimate. That's not my implication here. But patching is a treatment that any eye care professional will prescribe to treat amblyopia, to treat a lazy eye. That is not what we would consider vision therapy. Vision therapy is using eye exercises to treat a host of different things. I really think of it as like prescribed exercises. That's not all of vision therapy, but I'd say a large part of vision therapy. And I think some people disagree with me on the usefulness of it. I'm basically going on data. And if that's what drives what we decide to do. And if we don't have evidence base for doing things and treating certain conditions, should we be doing it? Probably not, but that doesn't mean we can't like study it and see if it's useful. And I wish I would love to see more data about vision therapy because it's a benign treatment, right? If you prescribe it for someone, it's mostly exercises, right? And maybe they use some lenses and things, but it's not, that's not going to be dangerous in just recommending that. And so it's something that I think can very easily, you have more research behind to see if it actually has a clinical basis, a clinical improvement, an evidence base to prescribe it. I would love to see more of that. And so anyway, that's my thought. I'm not going to go through all the vision therapy stuff again, but I appreciate some of the optometrists that sent me messages and left comments. I'm always open to, learning more about things that I don't do. And if you have some studies that you want to send my way, feel free. Let me see them. Okay, so another couple of comments here that I thought were pretty good. Oh, I like this comment. Uh, do your eyeball? This is from at Miss Vitabomb. Do your eyeballs explode? These are on YouTube, the YouTube channel at Glockenflecken. So go leave a comment. Do your eyeballs explode if you sneeze with your eyes open? Is this childhood rumor true? Unfortunately, it's true. Every day we see an exploded eye. No, it's not true, you guys. I think you're being facetious whenever you left this comment. But believe it or not, I have received that question several times because that's something I heard growing up, right? You don't sneeze. Guess what? You can't sneeze with your eyes open. I guess if you had a device that was strong enough to hold your eyelids open, I'm physically holding them open on the YouTube channel right now, so if you can go look at it. Then maybe, I guess, you could technically sneeze with your eyes open. What would probably happen, though, is because it's a reflex when you sneeze, let's say you had a speculum in that was holding your eyes open and then you sneezed. What would probably happen is you would damage the levator muscle, which is a muscle that's responsible for opening your eyes. Because what happens, and we see this with cataract surgery, when people squeeze really hard against the speculum during surgery, that's why we try to have people relaxed. When people squeeze real hard, they stretch out that muscle, and then it leaves you with a droopy eyelid. So if you tried to do that, you'd probably end up with two very droopy eyelids, and you would need a surgery where we shorten that muscle to help open up the eyes a little bit more. So yeah, you would just give yourself some ptosis. That's like worst case scenario. Your eyes will not pop out of your head. Eyes can pop out of your head. It's called ocular, what do we call it? Subluxation. The whole eye kind of pops forward. We see that with severe thyroid eye disease occasionally. Quite painful, not fun, but it happens. But not in the context of sneezing. Good question, though. All right, let's take a break and have a couple more comments to address. Hey, Krista, we're going to do something special.
What's that?
In honor of World Antimicrobial Resistance Awareness Week,
Mhm.
this month we're going to spotlight a podcast that's been host to some very powerful conversations about antimicrobial resistance. It's called the Sepsis Spectrum, hosted by Nicole Kupchik.
It's so important to get that information out there to people, and a podcast is a great way to do that.
It really is. Each episode is about confronting different blind spots in sepsis and antimicrobial resistance that just helps educate people. And it's not just fluff. All right, it's not just cold academics and CME. These are real conversations about real stories about real patients. You can listen to the Sepsis Spectrum wherever you get your podcasts, or watch it on Sepsis Alliance's YouTube channel. To learn how you can earn free nursing CE credits just by listening, visit sepsispodcast.org. All right, I had a comment from @Jeremiah Walgren. When did you know you had the stomach for practicing medicine? I feel a little queasy just from your descriptions of these injuries. So I think this is in response to, I discussed like a resistance band injury or a bungee cord injury, basically the things popping back and hitting you in the face, because I think it happened to an athlete recently. It's a common story. Honestly, I see a handful of patients every year with that exact thing. They're stretching something and it popped back and hit them in the eye. But the question, when did I know I had the stomach for practicing medicine and dealing with like the grossness of healthcare? I don't think I ever really like had an epiphany, like, I could handle that, so I must be able to handle going to medicine. I first thought about going to med school, and when I was a senior in high school. I was taking my AP biology class, my favorite class in all of high school, and we dissected a cat. I think it was like a fetal cat, and I was fine with that. Like that didn't bother me. I think if it had bothered me, if I was like unable to do that or see the internal organs, all that stuff, then that maybe would have planted a seed of doubt that maybe I shouldn't consider this. But even in college, I never did. I was a cell and molecular biology major in college. I didn't take an anatomy class. I took like all kinds of courses, so I would see pictures of gross things, but never anything in real life. The first dead body, the first cadaver I saw was first year of med school. So I was committed at that point. I was like, I signed the loan documents. I was going through with it regardless of whether or not I can handle it. I would say though, in college, the only thing that gave me a near vasovagal reaction. So for those of you who don't know what that is, you have some kind of, I don't even know what, for different people, it's like an intense stress reaction that causes your blood pressure to drop. You get really sweaty, you get nauseous, and we see this mostly in the world. We see this a lot in ophthalmology. Anything eye related, the eyes are like a thing for people in terms of like, you don't want people near your eyes, or just the thought of someone touching your eye or checking your eye pressure or doing surgery on your eye, even just discussing it with people. So I've had like just talking about cataract surgery with people, and I could see them start to vasovagal. They start looking a little pale. They maybe like drop their head a little bit. They start getting beads of sweat. I was like, oh, okay, let's lay them back. Vasovagal protocol, everyone. We should have a code for this. Code turquoise. I don't know. Code dark blue. It was some sky blue. Whatever. I'll workshop that. maybe code green for like feeling like looking green, like you're going to be sick. But anyway, we'll tip them back in the chair, get them laying down as best we can, and give them like a cold compress, a barf bag, and we just like give them some time, and then people come right back. It's fine. Very rarely do people actually fully pass out. I mean, it does happen, but it's only for like a second or two, and then they're back with us. But anyway, so that did kind of happen to me in college. I saw it was a course on sexually transmitted diseases, and there were pictures of diseased genitalia, some sore, some chancres, some hemorrhoids. Not hemorrhoids. That's not one. What am I saying? So, herpes. That's the word. Not hemorrhoids. Herpes. Little gonorrhea action happening. So that and that was, I remember very vividly. That was, I think it was a talk given by a pathologist. And so you can imagine he was this like super tall, bald, glasses wearing, very, very dry. The driest person, yeah, it was that you can think of, was giving us a talk in excruciating detail about the clinical findings of sexually transmitted diseases. And we were all college students. And I remember, I remember getting really sweaty. I had to leave the room briefly. Fortunately, oh God, it would have been so embarrassing if I had just collapsed and like fallen and hit the ground. That would have been rough. I did not. I managed to keep my feet underneath me, and I got outside and sat down, put my head between my legs. So maybe that's probably, and as it turns out, when I was trying to figure out what I wanted to do as a doctor, I tried to go as far away from the genitals as possible. And then now, I started ophthalmology residency in 2014. And so now we're a good, 12 years into this. And I have only seen one set of genitals. Is it a set? A pair? No, it would be a what do you, is, I guess that's how far away from this I am. I don't even know what to call them. Just genitals. I don't think you can have. I guess you can have one genital. I mean, I've got, with no testicles, I have zero genitals except the penis's genitals. So I don't know. I don't know the terminology. To be exact here. But the point is, I've only seen one person below the waist in my clinical life, and that was during residency. It was a patient that had a new complaint of floaters, and I promise you, this is going to make sense. I was in the retina service, and I had this old school attending. He'd been practicing for like 35 years, and he looked in this patient's eyes. And he then said, this is my recollection of it. He looked at this patient's eyes and he said, this is at the VA, by the way. Things are different at the VA, guys. Anyway, he looked in the patient's eyes. He said, hey, can you drop your pants for me? And of course, veterans, like, sure. Like, I'm surprised they even have pants already. They're probably just getting ready just in case something happens. They're just going to just take them off. So, and the guy dropped his pants, and sure enough, right then and there, diagnosed with syphilis. He had like inguinal lymphadenopathy. The guy, this old school ophthalmologist, has been practicing for 35, 40 years. He like did a genital exam. He was like, I think you got syphilis. Very impressive. Not something I would ever do. I don't in general, it'd be very unusual for an ophthalmologist to ever ask you to take your pants off. All right. Just be careful if you ever hear that. Yeah, I'd love to hear other stories of people, and we can hash them out and see if it was necessary for you to actually take your pants off in front of an ophthalmologist. But it doesn't happen very often, if ever. I've never done it personally myself. Why was I talking about? Oh, because the question is, when did you know you had the stomach for practicing medicine? So anyway, that was I always, the human body doesn't bother me, but I guess just sexually transmitted diseases does. Sores and things on the genitals, I guess, are not my cup of tea. But I probably could have done anything. I considered so many different specialties. I considered OBGYN at one point, which I guess now makes sense that I wouldn't want to do that because I think there are sexually transmitted diseases involved there. So maybe that's not my an area I should have explored. I loved the babies. I loved the whole thing, delivering babies. It was just really such an amazing event. I really actually like the personalities too. At least at the hospital that I was doing my rotation. That was my very first my second clinical rotation. And it was I just loved the people. It was just an amazing thing right at the beginning of my career. So I was like, oh, maybe I should be a OBGYN. And then I thought maybe cardiology at one point. Radiology was a consideration before finally landing on eyeballs. All right, let's see. I've got a few other little random topics, ophthalmology topics that we can talk about. Let's see if I have any other comments. I don't think so. Nothing else that I thought we would talk about. The ophthalmologist needs to feud with physical therapy over resistance bands at Curoi XHF. That's actually not a bad idea. Oh, I did have one other topic to talk about. So this is more of a question that I've been wondering about. Do professional athletes, I would love to know, do they get regular eye exams? Over the years, I've heard of these stories. I think the last one I heard about was maybe Jameis Winston. Jameis Winston, he won a Heisman at Florida State. He's kind of had an interesting up and down career in the pros. He's like a kind of a career backup type of guy. But I remember seeing a story where like he halfway through his career, he realized he needed glasses and then he started playing better. And so you would think, and maybe people just don't realize this, like you would think that when you're doing a physical for athletes, shouldn't an eye exam like be a part of that? You go see an ophthalmologist or an optometrist just to see, like, do you need glasses? Because the thing is, you grow up with a certain vision. And if you're like a little bit nearsighted, let's say you're like a -1.5, -2, that's good enough to be able to drive. Barely. Like, let's say you have uncorrected, you have 20/40 vision. Like that qualifies you for a license in pretty much every state. But some states you can have 20/50, 20/60, 20/70 vision and still qualify for a license. But that vision is not going to be good enough to hit a baseball. Or you can, but you're not going to hit it very well or see a receiver with the right colored jersey so you don't throw interceptions. So it's like I have no idea if at the professional level, I played sports through high school. I never got an eye. No one ever told me go get your eyes checked. I mean, there's no reason to be concerned, but I got my testicles checked for a hernia. Like every year. So I remember like they lined us all up in a big gym, big line of boys. We all dropped our shorts and the doctor just went by one at a time, changing their glove, checking all of us, cough over your shoulder. Wild times. I don't know how they do it these days, but man, but no eye exam. So let's get these athletes eye exams. Maybe that could be career changing. Can you imagine like you're living life seeing 20/50? You've never had an eye exam. You just assume that your vision is perfect, that it's normal because you're able to function well enough, right? You can see the front of the classroom pretty well. Maybe not as well as you could. And then like when you're 25, all of a sudden you get an eye exam like, whoa, I never realized I could see this well. Like, let's help these kids out. Get your eye exam. If you're an athlete and that requires very high acuity vision, especially like baseball, football, tennis, golf, like go get your eyes checked. It doesn't hurt. Like just do it. All right, let's take a break. Hey, Kristen.
Yeah.
You know what it's time for?
What?
More Dex Blepharitis talk.
Yay!
We're not talking about mites today, though.
Okay, phew.
All right. I've mentioned the crusties. Remember the crusties? The collarettes?
Yes, I remember
right? It's a
eyelid
telltale
crusties.
sign of Dex Blepharitis. I just want to educate people that you can't always see these things in the mirror.
Mm.
Sometimes you need magnification, the equipment we use in the eye clinic to be able to diagnose this.
So some people might not even realize it when they have Demodex blepharitis?
Exactly. Often patients don't know they have those crusties and can't connect their symptoms of redness, irritation, itchiness to Demodex
Because that just
blepharitis.
sounds like allergies.
It can be. It's also a great time right now to make an appointment with your eye doctor before the end of the year when deductibles reset.
Ooh, good point.
Yeah. To see more pictures of crusties and eyelids with Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, we're back. I got a couple of possible topics here. I'm just gonna do one that's real quick. Lyme disease. How about that? Occasionally, I'll get asked about, someone thinks they have Lyme disease, chronic Lyme. I'm not the person to. I know chronic Lyme. The idea of chronic Lyme. It's like lots of people in the healthcare field like think that that's like not a real thing. There's a whole lot of people out there that do things. That is outside my. I've not put the time in to try to figure out what Lyme disease is. About surrounding chronic Lyme, I should say. But Lyme disease is something. I mean, it is a disease. Whether or not it's like acute versus chronic, I don't know. Ask an infectious disease doctor. Know your limits, people with podcasts. See, and it's okay to talk about that. But I do know that Lyme disease, traditional like acute Lyme disease, can affect the eyes. All right, so you can get. It's one of those diseases, kind of like syphilis, where it can look like a lot of different things. And I don't know if we really know the pathophysiology behind how it happens, but some of the more common ophthalmic manifestations of Lyme disease um, include, just blurry vision, double vision, pain, light sensitivity, because it's an inflammatory disease. So you get inflammation that can cause these things. You also get facial weakness, which can affect the eye. Because if you have like a Bell's palsy associated with Lyme, I guess if it's Lyme, it's not considered Bell's palsy, but a facial paralysis from Lyme disease, then as we talked about earlier, you can't close your eye completely. All right. And so you have weakness of your eye muscles, of your eyelid muscles that cause you to have a perpetual open eye, and that can lead to severe dry eye problems. Conjunctivitis is the most common manifestation of acute Lyme disease. All right. So you get just a little redness, a little bit of discharge, and all of these things that you would treat it like you would treat Lyme disease. You treat it systemically. I still think doxycycline is the mainstay of treatment for early Lyme disease, but you escalate the treatment if there's signs of neuro-ophthalmic issues. So any sign of optic nerve involvement, optic nerve swelling, that would be very serious and indicate you, because obviously you got to think of the optic nerve. It's part of the brain, the retina, the nerve fiber layer of the retina, part of the brain, and so you have to be careful. Anybody with Lyme disease, diagnosed with Lyme disease, definitely should have an eye exam. So I don't have a whole lot else to say about Lyme disease, but I do get questions occasionally about Lyme. Not as much where I live now. I saw it a lot. I saw Lyme disease a lot, but also questions about it when I was doing rotations up at Dartmouth when I was a med student, trying to get my application ready. You'd see people come in with Lyme disease. They'd come in for their eye exam, and most of the time there wasn't any eye involvement. I'd say it's fairly rare that we actually see that. All right, your final potpourri ophthalmology topic is accommodative spasm. This is something that we've seen a lot of over the last 10 years as screen time gets higher and higher with each passing year. You have, and I've seen this with my kids' friends, is wild. Like they're texting and they're holding their phone. I sound like an old guy, and I understand that. I'm embracing it. I'm 40 now, they're holding their phone like literally 2 inches from their face, not even nearsighted kids. They can do it. They can focus up close. This is about as far as I can do like 8 inches. If I get closer in, my eyes can't do it. I cannot focus that close. If I try, I'll get a headache. That's what happens with accommodative spasm, is that you spend so much time near work firing those ciliary muscles, those muscles that are responsible for accommodation, that allow you to move your focal point from distance up close. That's what you're doing when you're reading. You're firing your accommodation. You're firing your ciliary muscles, allowing you to accommodate. Well, if you spend hours and hours and hours doing that, like kids can do, people in their teens, 20s, even early 30s can do it all day. Sometimes you develop a spasm where you can't relax. And I've seen people come into clinic like this, young people. They're like, my distance is really blurry. I have a headache. That's the classic. That's what the presentation is right there. You get a strain above your eyebrow, right across your forehead. And so what we'll do in clinic when people come in with this is we'll give them drops to relax their accommodation. We give them cyclopentolate drops. It breaks it because it forces those muscles to relax because it paralyzes them. Paralyzes your ciliary muscle. So you can't accommodate. And I've seen the headaches go away in real time. Everything just relaxes. All of a sudden their distance vision is better. And so it's like magic. But then we talk to them about like, okay, why did this happen? You need to take breaks. This is why like working or studying next to an open window is fantastic, because you can study and work for like an hour, take a break, look in the distance. Very important. Look somewhere far away. When you're taking a break from that, don't just go to your phone. Actually, go for a walk. Look in the distance. Look at trees across the way. It's really helpful, no matter what age you are, for just allowing your eyes to relax, and you can avoid that spasm. And that's pretty much it. I mean, it's a very simple one, but we don't prescribe those eye drops because often we can just break it by applying them, and then then it's about prevention from there on. So prevent accommodative spasm, you guys. Take breaks. Look in the distance. It's good for you. All right, that's it for Knock Knock Eye. Thank you to my producers, Aaron Cordy, Rob Goldman, and Shanti Brick. I am Dr. Glaucomflecken. This is a human content production. We'll see you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.